and welcome to my YouTube channel. My name is Wangoi Mwangi and this channel is Nursing with Koi. If you are new here, please take your time to subscribe and hit the bell icon so that you're notified every time I upload an informative video such as this one. Today I want to discuss about endometrial cancer, and this is one among the cancers that sadly affect women right here in Kenya and globally, and there is treatment for both right here in Kenya and above the borders or beyond the borders. But for this I will try to focus more on its epidemiology here in Kenya and treatments right here in Kenya. So let's dive right in. So to understand endometrial cancer, it is important to understand the anatomy of the female reproductive system, beginning with the ovary, the fallopian tube, and then the uterus. So the endometrium is part of the uterus, and the uterus has three main parts. The cervix, comes from the end of the vagina all the way to the endocervix. Then we have the isthmus or the body cavity of the uterus or the uterine cavity, and then we have the fundus. So the fundus is the topmost part of the uterus, and within it, the entire uterus is made of three layers. The endometrium, which is the innermost layer, then we have the myometrium, and then we have the perimetrium. So today we are discussing endometrial cancer, which is a type of uterine cancer affecting the innermost layer of the uterus. So it is what covers around where the baby actually attaches is in the endometrium, and whatever causes the shedding during menses again is from the endometrium. So let's see how this happens and the pathogenesis therefore. To introduce, endometrial cancer is a type of uterine cancer that starts in the inner lining of the uterus. This lining is called the endometrium, and nearly all cancers of the uterus start in the endometrium and are called endometrial carcinomas. However, there are other cancers that can originate from the uterus, and usually in the muscle layer or the supporting connective tissue of the uterus, and these are called uterine sarcomas. For the purposes of this video, we are going to concentrate more on the endometrial cancer because it's most common and usually develops slowly and often occurs in postmenopausal women, and sometimes has been referred to as a silent killer because you never know until it is too late, because there are no specific symptoms for this cancer. So the uterus is a hollow organ in females located in the pelvis, commonly called the womb. The uterus functions to support the fetal development until birth. So this is where the fetus actually develops, or the house of the baby. The uterus is shaped like an upside down pear, and the top is called the fundus, the middle the corpus, and the bottom is the cervix. The inner layer of the uterus is the endometrium, and the outer layer of the outer layer is the muscle called myometrium. The uterine cancer is the abnormal malignant growth of any cells that comprise uterine tissue. The buildup of cancer cells may form a mass or a malignant tumor, while non-cancerous cells that form a mass are called as benign tumors or myomas or fibroids. The uterus has three sections, mainly the cervix, which is a narrow lower section, the isthmus, which is a broad section in the middle, and the fundus, which is a dome-shaped top section. The uterus is made up of three layers, and that is the endometrium layer, the myometrium layer, which is the thickest, and the serosa, which is the thin outer lining of the uterus. So epidemiology, the prevalence in Kenya is unknown about endometrial cancers, but hospital-based data show that for every 30 cases of cervical cancer, there is one case of endometrial cancer. Lifetime risk of developing endometrial cancer is approximately 2% in the USA. It's approximately 6,000 deaths annually. About half of patients with endometrial cancer have risk factors for the disease, including obesity, unopposed estrogen exposure, estrogen-secreting ovarian tumors such as granulosa and thicker cell tumors, older age, chronic anovulation, low parity and nulliparity, early menarche, that is onset below 12 years, and late menopause above 52 years. Then the use of tamoxifen, diabetes mellitus, and history of breast or ovarian cancer. So looking at epidemiology in another format, uterine cancer or the endometrial cancer is the most common cancer of women's reproductive organs, and it is the sixth most common cancer in women worldwide. It is the fourth most common cancer in women in the USA, and this attributes to about 320,000 cases diagnosed globally. 82% of patients diagnosed with endometrial cancer survive for 5 years. Around 60,000 new cases were diagnosed in 2016. Approximately 49,600 cases were diagnosed each year, in the USA. Physical activity reduces the risk of endometrial cancer by 59%. 3,900 cases were diagnosed in the UK, while about 2.8% of American women were diagnosed with endometrial cancer. Endometrial cancer incidence is low in India. The signs and symptoms of endometrial cancer include some of the following, but not exclusively. Signs of endometrial cancer include abnormal and heavy bleeding, that is heavy uterine bleeding, difficulty or pain while urinating, pain during sexual intercourse. Some people may have no symptoms at all. There may be lack of menses or lack of bleeding. There could be watery discharge that could be foul smelling or not, and then there is pain in the pelvic area. Risk factors include overweight, having polycystic ovarian syndrome, early menarche or early menstruation, and that is below 12 years of age, and diabetes, high estrogen levels, having no children, that meaning you have never had a pregnancy in your life, the presence of fibroids and polyps, and late menopause. So if your menopause comes above 52 years, that is considered late, and about menstruation, if it is menarche below 12 years, that is considered way early. So if you have had such, then you need to get screened for the same. Screening includes endometrial biopsy, dilatation and curettage, ultrasound, MRI, and CT scans. Regular checkups do not screen for this cancer, and therefore you have to speak up if you're experiencing any of these symptoms listed here. So when it comes to diagnosis, abnormal vaginal bleeding, including postmenopausal bleeding, spotting occurs in 90% of patients. Though most patients are postmenopausal, about a quarter of them are premenopausal, with 5% below 40 years of age. Majority of young patients are obese or have high levels of unopposed endogenous estrogen from chronic anovulation or from polycystic ovarian disease. Initial evaluation should include full physical examination. That means a pelvic examination noting the size, position, and contour of the uterus. Screening for cervical cancer should be performed, and diagnosis will require histopathological evaluation of the endometrial tissue. One should consider primary endocervical adenocarcinoma or extensions of the cervix or cervical carcinoma into the endometrium. Therefore, both endocervical and endometrial sampling should be performed. Devices for use in the office allow endometrial sampling and accurate diagnosis. Hysteroscopic evaluation and biopsy may be performed where facilities are available. Pelvic ultrasonography may be suggestive of disease. More than 90% of all cancers are endometrioid in type, and the other types are serous, clear cell, mucinous, mixed cell, transitional cells, and sarcomas. So the next thing we are going to look at is the staging, and before we go into staging, it is important to notice the degree of differentiation because it's something that is used during histological differentiation and grading the type of tumor one has. So histological differentiation is important in determining treatment and prognosis. Response to treatment decreases with increasing grade of assigned cancer. WHO grading includes grade 1 is non-squamous, non-morular solid growth pattern in 5% of the tumor, while grade 2 is non-squamous, non-morular solid growth pattern in 5 to 50% of the tumor, and grade 3 is non-squamous, non-morular solid growth pattern, and this is in above 50% of that tumor. We go into figure staging for endometrial cancer, which was developed by the World Health Organization again, and we have 4 distinct stages, and all of them will have more than one substage. So we are going to look into the stage and the anatomic involvement in that stage. So beginning with stage 1, The tumor is confined in the uterine corpus, and in 1A there is no myometrial invasion. In 1B there is less than 50% myometrial invasion, while in 1C there is more than 50% myometrial invasion. This means that there is the tumor is in the endometrial tissue or the lining, but then it has also invaded the myometrium. Remember, the muscular layer of the uterus has also been invaded by this tumor. So by the time you're getting to stage 1C, more than 50% myometrial invasion is involved. Then we proceed to stage 2, and this is where we get to cervical involvement. So in stage 2A, there is endocervical glandular involvement, and while in stage 2B, there is cervical stromal invasion. Then we move on to stage 3, and in stage 3 we have 3A, B, and C. So in 3A we have positive peritoneal cytology or tumor invasion into the uterine serosa or adnexal involvement. While in stage 3B there is vaginal involvement. When we go to stage 3C, there is metastasis to the pelvic or the pelvic lymph node. So there is much more spread in 3C compared to the others. While we get to stage 4, this is quite advanced disease and it has A and B. Stage 4A is where the bladder or bowels are involved, and there is distant metastasis including abdominal. Distant metastasis is stage 4B, including abdominal disease, inguinal lymph node involvement, and the rest of the body. So the higher the grading, the higher the stage, the worse the prognosis, the harder it is to treat, and therefore it is very, very important for anybody experiencing the symptoms mentioned above to get checked out, because it is not normal to have pain, it is not normal to have disorderly uterine bleeding, it is not normal to have some of those symptoms, and even if it is okay to just go get checked out, because if it is caught early, there is a possibility of getting to remission or treating it to a place you can say it has been cured. So now that we have looked into staging, let us look at risk categorization. So there is low risk, intermediate risk, and high risk. Low risk is stage 1A and B, grade 1 or grade 2. And this is usually endometrioid histopathological type. When we come to the intermediate risk, this is stage 1C, grade 1 or 2, and then stage 1A and B, grade 3, and then endometrioid histopathological type in both. When we come to high risk, we have stage 1C, grade 3, endometrioid histopathological type, stage 1A, B, and C, serous, clear cell, small cell, and undifferentiated histopathological type. So you could be having grade 1 of whichever stage, but for as long as it is serous, clear cell, small cell, and undifferentiated histopathological type, then that is severe disease and it is high risk. When it comes to the management, surgery is the mainstay of treatment. This involves total abdominal hysterectomy or TAH and bilateral salpingopectomy or BSO. Chemotherapeutic regimens containing doxorubicin, cisplatin, carboplatin, paclitaxel, docetaxel, topotecan, ifosfamide, 5-fluorouracil, and methotrexate are mainly administered. These are usually administered in various combinations, but single agents can also be used. High-dose medroxyprogesterone acetate may also be included in steroid receptor positive cases. So commonly used medications for this disease include cisplatin, carboplatin, paclitaxel, docetaxel, doxorubicin, topotecan, ifosfamide, vinorelbine, and tamoxifen. In resource-limited settings, cisplatin with doxorubicin is the preferred treatment of choice, while where resources are available, a taxane and a platinum compound are used, such as, let's say, taxanes are paclitaxel, docetaxel, and that kind, while platinums are cisplatin, carboplatin, oxaliplatin, so those are platinum compounds. Then early stage presentation is curable with surgery alone, so that is why I am insisting that if you're experiencing any of these symptoms, see your healthcare provider as early as possible, because if caught early, it could be cured with surgery. However, if disease has advanced to a certain level, there will be surgery and there will be chemotherapy, and most likely radiotherapy in later stages. So listed in these slides are the references that were used to develop this content for this endometrial carcinoma. Feel free to go through them. Feel free to look for the Kenya Cancer Management Guidelines because a lot of this information is provided there as well. Thank you so much for watching through this video and for supporting my channel. Please, if you have not subscribed, please do so. It is free and it is free of charge, but it is very helpful for the channel growth and it will keep encouraging me to make these videos. So until we see each other again, bye and ciao.